And good afternoon, everyone. I think we are now live. It's 1 o'clock and we're going to get started. So good afternoon and welcome to our live webinar for Thursday, June 11th. All right, click and go. So Tuesdays and Thursdays are our walk and talk sessions with Rob. My name is Rob. I am your host. For those of you who've been tuning in, you know that what we're going to be doing is going through an exercise session. And for anybody who's familiar with our program, you should see a lot of similarities. We'll start off, we'll do a dynamic warm-up at the start of exercise. We'll do a little bit of aerobic warm-up just to get our hearts ready for the exercise. We'll do some cardio. We'll do a cool down. We'll do some resistance training. We'll do some stretching. And as long as I don't talk too much, we should be done all in about 30 minutes or so. Right, so just a couple of reminders for everybody that while these exercises should be doable by pretty much everybody, it's always a good idea to make sure that you get clearance from your doctor to do any kind of structured exercise. So please make sure you do that. I'm always saying that we should be looking to exercise pretty much 5 days of the week is what we tend to encourage. I do these on Tuesdays and Thursdays, so that's only 2. So these sessions are recorded. They're hosted on our website on cardiaccollege.ca, and hopefully you can use them to do 3 more workouts on your own, because that is our targets. All right. We should also make sure that when you're doing the exercise, you're not feeling any pain. You should be comfortable. It's okay for your breathing rate to go up a little bit. I mean, we are doing some exercise, so that's acceptable. You might feel a little bit of fatigue in your legs because we're going to be doing mostly marching, but that's pretty much it. If you have any chest pain, dizziness, lightheadedness, symptoms, anything like that, please stop the exercise. And if stopping the exercise does not get rid of the symptoms, please access EMS. All right, so hopefully everybody's been feeling well. Yesterday was a bit of a scorcher of a day, so I'm assuming not a lot of people were outside doing their exercise, at least not in the middle of the day. Hopefully you're feeling well now, no chest pain, shortness of breath, dizziness, no other symptoms. For those of you that are taking medications, hopefully you have. And for those of you that are diabetics, hopefully your blood sugar is at a safe level, with the reminder that exercise can lower your blood sugar, so you don't want to start with a low value. Okay, so we're going to get that out of the way. Let me get rid of my PowerPoints. All right, folks, as always, before we do our exercise, it's not a bad habit to check your resting heart rate. So let's start off getting your resting heart rate. Once again, you can get it here in your wrist on the inside aspect of your forearm on the thumb side. You'll feel your radial pulse thumping away in there. If you can't feel it thumping away in there, sometimes the pulse is a little bit stronger in your neck and your carotid. So if you can find your pulse here in your neck or in your wrist, and I'm going to give you a 10-second count starting right now. And stop. Okay, so hopefully you've been checking or in the habit of checking your resting heart rate, and you'll find that your number is similar to what you usually get. Okay. First thing we're going to do is our dynamic warm-up. So we'll start off with just a little bit of light marching. Once again, the aerobic exercise that we do is going to be marching in the spot, so it makes sense to get our marching muscles, our legs, get them warmed up. Gets the muscles going, gets the knees, the hips, loosens all that stuff up. So we're good for our exercise. I'm going to do this for about 30 seconds. Okay, done our marching. Next thing we want to do is loosen up our hips. So for that, you're going to hold on to something for a little bit of balance. I'll hold on to my friendly fridge here, and then we're going to do some hip swings. Just slow, deliberate movements. You should be looking forwards. I'm looking over my shoulder so you guys can hear me. And no pain with this, just slow and deliberate, just to loosen the joints up, get them ready. Okay, and then let's do the other leg. Just about 15 seconds a leg will do. Okay, good. And now let's do our ankle rotations. Probably a good idea just to lean against something when we do these. And then you're just trying to draw a nice big circle with your big toe. Just like with the hip swing, slow and deliberate. Make sure you get both directions. There we go. And then let's make sure that we get both feet. And get both directions. Great. And then let's just finish off by loosening up our shoulders, our upper back. And make sure you get both directions. Okay, so that's our dynamic warm-up. So the next thing we're going to do is we're just going to start with our aerobic warm-up. And for our aerobic warm-up, you want to do whatever activity you're going to be exercising at, just at a little bit of a slower rate. So for us, it's just going to be marching on the spot. Don't have a lot of room in my kitchen. And we do this for about 4 or 5 minutes. So let me see, questions that have come in the last couple of weeks. On our last session on Tuesday, we spent a little bit of time talking about heart valves, what they are, the role they play in the heart, some of the problems, symptoms that they might cause, and some of, at a very high level, some of the treatments for valve problems. For whoever asked me that question, hopefully that answered it adequately for you. For today, we had a question about stents. So once we've done our warm-up, we're going to talk a little bit about cardiac or heart stents and angioplasties. That'll be our topic. There were a couple of other questions that have come in, and just so that you know, we're not ignoring them. There's been a question about the proper way to use walking poles. So we're trying to find out what we can do with that. My colleague Crystal is trying to find a resource for it. Part of the problem, I won't lie, I know a little bit about the physiology of walking poles, just don't know how to teach them how to be used properly. That's on me. So we're trying to find somebody to help with that. And the other question that we had is just about diabetes. So I'm excited about this one. My colleague Renee Canitas, who's heavily involved in our diabetes program, is going to join us in one of the coming sessions, hopefully next week. I'll do my exercise and she'll be able to remote in, and her and I will have a discussion about diabetes and exercise. So that will be coming up. And I think that answers the outstanding questions that we've had. If anybody else has anything else they want me to talk about after today's session, please put it in the Q&A, the chat feature of our Zoom cast, so that I have topics. Otherwise, I'll be telling you about my last vacation or something, which would be pretty boring. Okay, so we've got about another 2 minutes or so to do our warm-up. In case anybody's wondering about the time. I have to say hello to one of my patients I was just chatting with this morning, Mary Lou. Hopefully you figured out how to make this all work and you're joining along, doing some marching with us. That would be great. Okay, so I guess I can start talking a little bit about stents. All right, so let's see, how can we talk about stents? Well, in the past, we've talked about the heart being a wonderful organ. It's got a very simple job. Your heart is meant to supply all the cells, all the tissues in your body with oxygen-rich blood. All the cells need oxygen-rich blood to produce energy. And it's your heart's job to make sure that happens. So it's got different chambers in the heart, and it pushes the blood around. Your heart does an awful lot of work. I think you guys have heard me say it beats about 100,000 times a day. So a very, very hard-working organ. And helping your heart do all of this work are a variety of different systems. So, for example, last session on Tuesday, we talked about the structural systems of the heart. So that's like the walls and the valves. The valves help control the flow of blood through the heart. We've also mentioned that there's an electrical system in the heart. And last Monday, our medical director, Paul O., talked about arrhythmias or problems with the electrical system. And I've also mentioned that the heart has a plumbing system. And that's really going to play a big part of our talk today. Every cell in the body needs a constant supply of oxygen-rich blood, including the heart. And the heart gets its oxygen-rich blood through what are called the coronary arteries. I'm going to interrupt briefly. That's the end of our warm-up. So if people want to pick up their walking pace a little bit, now would be the time to do so. So every cell in the body needs oxygen-rich blood. So too do the cells of the heart. It gets its oxygen-rich blood through two coronary arteries, one on the left, one on the right. They're creatively called the right and the left coronary artery. We know that different things can happen in the body, including in the coronary arteries. Ideally, the coronary arteries are supposed to be nice and smooth. Nothing really sticks to it. A lot of people say it's like a brand new frying pan. Well, we shouldn't be using frying pans to fry stuff, right? Don't let our dietitians hear me talk about that. But nothing sticks to it. What happens with coronary artery disease is something will act on the lining of the coronary artery to damage it. And that something is typically the risk factors that you hear about: high blood pressure, diabetes, cholesterol, that kind of stuff, lack of exercise. They all will interact with the lining of the coronary artery in a slightly different way. Almost all of them result in a weakening or damaging of the coronary artery. The one that, for me, has always made the most sense is like high blood pressure. If you've got a well-controlled blood pressure, for every one of those 100,000 heartbeats a day, the pressure on the artery is well controlled. It's not a problem. But if you have high blood pressure, you can imagine that pressure pounding on the artery 100,000 times a day is just going to start to do mechanical damage to the lining of the artery. And once you damage an artery, you weaken it. A damaged and weakened arterial wall lays the groundwork for the buildup of blockages, a process called atherosclerosis. Once you've weakened an area of wall, smooth muscle cell will start to kind of grow through it a little bit. You've got excess cholesterol. Cholesterol will get deposited into that weakened area of wall. White blood cells, over a long time calcium. All this garbage starts getting deposited into this weakened area of arterial wall. And that's a problem, because as you start putting more and more stuff into this weakened area of wall, it will start bulging and swelling. It's kind of like if I had a carpet here on the floor. If I sweep a little bit of dirt under the carpet, no one's going to really notice. But if I sweep a little bit every day, day after day, year after year, you can imagine I'm going to have this big mound of dirt under the carpet. Well, if I start depositing more stuff into this weakened, damaged area of arterial wall, it's going to start to bulge into the lumen of the artery. The lumen of the artery is the middle part. That's the part where all that beautiful oxygen-rich blood is supposed to flow through. And if I start bulging into that lumen, I leave less and less and less room for oxygen-rich blood to go through. Eventually, I'm going to get to the point where I've restricted the flow of oxygen-rich blood through that part of the artery enough that the heart can't get all the oxygen-rich blood that it needs. That's the case. It's not going to function as well. You can have problems with the pumping power of the heart. It can weaken that a little bit. It can irritate the electrical system. So you start to get a short circuits, arrhythmias, skipped beats. And a lot of the time, your heart will complain. And it will typically complain by causing a symptom. And when that happens, this is angina. We talked about that, I think, 3 or 4 sessions ago. So how can you prevent this process from happening? Well, that's why we talk about risk factors all the time. If you can control your risk factors, you decrease the odds of the development of coronary artery disease. So that's one thing. Unfortunately, here in our program, people have already got established coronary artery disease. So what do we do in that point? Well, if you've got established disease, you still want to make sure it doesn't get worse, which is why even here we talk about controlling your risk factors. We know if you can control your risk factors, you'll decrease the rate of progression of those blockages. In a lot of cases, you can actually stop the progression. The really exciting thing, in some cases, you can actually get the blockages to shrink a little bit. Something called regression of coronary artery disease. If the blockage gets to about 50%, doesn't usually cause a lot of problems in terms of blood flow. Your arteries are pretty robust, and they can deal with a lot of small blockages. As a matter of fact, anything up to 50% usually isn't going to cause you any problems. From 50 to about 70%, it's going to cause some blood flow problems that can affect your heart. Your heart might complain and get angina. But a lot of the time, for those 50 to 70% blockages, we can manage them with medications. If you've got a blockage between 50 and 70%, that decreases the amount of oxygen-rich blood your heart can get. Well, we can give you a medication like a beta blocker. These are these medications that end in OLOL. Metoprolol, bisoprolol, sotalol, carvedilol, nadolol, the whole bunch of them. What these medications do is they slow down your heart rate and you slow down your blood pressure. And by slowing down your heart rate and slowing down the blood pressure, we decrease the need for oxygen-rich blood. If you've got a blockage in an artery and you can't supply much oxygen-rich blood, but we can give you a pill that makes it so you don't need as much, that's a nice balance. And a lot of the time, blockages between 50 and 70% can be managed just by changing the heart's need for oxygen-rich blood with medications, which is great. Once you get to about 70% and more, the blood flow is frequently compromised enough that medications on their own are not going to be enough. And that's when you might need to see your doctor, who's going to try and intervene with a procedure. The most common procedure that we have nowadays to deal with blockages in the coronary arteries is something called a percutaneous coronary intervention. It's called a PCI. So PCIs have been around for decades now. I think they started in about the 80s, in and around there. And what they do, your doctor will take a catheter, basically a metal wire, a whole bunch of stuff inside of it. The end of the catheter, they have got a deflated balloon. And what they'll do is they'll make an incision. Back then, it used to be in your groin. They put this deflated balloon that's on the end of the wire into your arteries, up your aorta, into your coronary artery, and they'll find that coronary artery that's got the blockage in it. What they'll do is they'll park the balloon in there, the deflated balloon, then they'll blow the balloon up. And literally, as the balloon blows up, it's just going to push that blockage out of the way of the blood flow. It'll pack it up against the wall of the artery. And I know when my colleagues and I take a look at the notes from your doctors, they'll say 95% blockage reduced to 2% or 3%. So initially, these balloon angioplasties worked really well to get the blockage out of the way. But they weren't 100% successful. About 1 in 3 of these procedures didn't work. Sure, you'd push the blockage up out of the way, but within a few months, it would collapse back down, and then your blockage came back, and you'd have to have another balloon angioplasty. So doctors are great. They're always trying to find the best way to manage and help patients. They're always tinkering. So somebody thought, well, if we can push the blockage out of the way, but occasionally it collapses back down, what if we were to put something in there to prevent that, like some scaffolding? All right, that's where stents came about. A stent, a coronary artery stent, is a small little device that's wrapped around the deflated balloon, goes in through the groin. Actually, a lot of the time now they're going in through the wrist. Both places lead to the heart. Just easier to deal with a hole in your wrist than it is a hole in your groin. So they tend to go for wrist first. They can't get in your wrist, they can do it through your groin, and that's fine. So the catheter goes in, and then the deflated balloon and the stent go in your in one of the arteries, up your aorta, into your coronary artery, into the narrowing, the blockage. They inflate the balloon pushes the stent pushes the blockage up against the wall of the artery. And they do this a couple of times just to make sure it's really packed up against the wall well. They deflate the balloon, pull the balloon out, but that stent is left in place. And that acts as scaffolding, and that decreases the odds that the blockage will collapse and come back. So this was a fairly cool invention. The rates of blockages returning improved to about 1 in 10. Whereas just with a plain old balloon angioplasty was maybe 1 in 3. Now it's 1 in 10. So real big progress. But once again, doctors, you know, they want to do the best job they can, so still tinkering. Okay, you know what? I'm just looking at my time here. Last week I got taken away. So let's get our exercising heart rate here for 10 seconds. All right? I'm looking, we're at about 22, 23 after. So find your heart rate. Make sure you keep your legs moving. Sway left to right just like I'm doing. And start counting in 3, 2, 1, go. And stop. Okay. So hopefully your exercising heart rate was in your normal range. That range is going to vary for everybody. As long as it's normal for you, that's what we're after. Now we're just going to do a little bit of a cool down. So keep marching, just go a little bit slower. And I'm going to finish off my story with stents in our cool down here. So they put the metal stent in, and that worked about 90% of the time. But doctors are always tinkering and trying to find better ways to do this. Those initial stents were just made out of metal. As a matter of fact, that's what they're called. They're called bare metal stents. And if you've had one and you've got a little card that gives you information about your stent, it'll say BMS, just stands for bare metal stents. So, only because I've only got 4 minutes, this is complicated. There's a number of different reasons that the stents would fail. One of them is literally an overhealing of the stent. Normally, if you put a stent in an artery, after a couple of months, you'll get a new layer of endothelial cells over top of the stents, which creates a nice smooth layer. Nothing sticks to it. Some people will grow multiple endothelial layers. And it's kind of like if I have one carpet here, that's fine. If I put 200 carpets here, that's going to be a big step. It's the same thing with the healing. If you overheal, you have many, many layers of endothelial cells. That's going to narrow inside the artery and you have a problem. So the next evolution of the stents was into something called a drug-eluting stents. They used a chemical that, interestingly, the idea behind it came from breast cancer. We know in cancer, you'll get a clump of cells that just grows far too rapidly. Cells don't function properly, and they invade the tissues around that. That's what the cancer tumors are. So tamoxifen is a drug that we gave to women with breast cancer that went to the tumor and just said, listen, don't grow so fast. Kind of stop growing. So doctors were thinking, if bare metal stents are overhealing, let's put a drug like tamoxifen into the stent, and maybe we can prevent that overhealing inside the stents. And if we prevent the overhealing, you're not going to get the multiple layers and the stents would be open. So it works maybe a little bit better than just a bare metal stent. It's quite complicated, definitely beyond my knowledge base. There's a whole list of criteria where a bare metal stent is your best option or a drug-eluting stent. And if you talk to your cardiologists out there, they would be able to explain way better than me. But that was the next evolution. They created, if you look on your little card with the information, the letter DES stands for drug-eluting stents. So that's about stents. 15 minutes to answer the question. And the question was, how long does a stent last? You put a stent in your artery, it's going to be there for the rest of your life. It doesn't dissolve, it doesn't go away. It's in there, it stays in there forever. If you're going to have any problems with the stents, they tend to happen quite early to the procedure. There's a couple of different things that we'll see with stents. Sometimes when you put a stent in there, acutely within a short period of time, days, you can get a blood clot that forms. I mean, let's face it, the body doesn't like having stuff in it that doesn't belong. If I put a hunk of metal in your body, that doesn't belong, so the body can sometimes attack it. You get some clotting in there. So that's one thing that happens sometimes. We can mitigate a lot of that risk by giving you medications, Brilinta, clopidogrel, Plavix, that decreases the odds of that happening. The other thing is this overhealing. All right, sometimes no matter what your doctor tries to do, some people will just overheal. That overhealing process tends to happen within about the first 6 months, roughly. Everyone's a little different, right? So it's not absolutely 6 months, but around 6 months. Once you get beyond that, though, typically you shouldn't have any more problems with the stents. You can still get blockages in there. I mean, if you're eating crappy food all the time and smoking and not exercising and none of your risk factors are controlled, you'll still get more blockages forming in there, stent or no. So if you have a stent, you still got to control your risk factors. But once it's in there, generally you tend to be okay. All right, hopefully that answered this, the how long does a stent last question. Forever, but control your risk factors and exercise. All right, so let's do our 2 resistance training exercises today. I think on Tuesday we did our step lunges, so today I'm thinking it's squat day. So let's get a chair out, something nice and solid. Squats, once again, it's going to work the big muscles in the legs. You guys know I like to call this the king of exercises. My balance is not great, so when I do my squats, I like to hold on to something. I'm going to use my kitchen sink, and then my feet are about shoulder width apart. I'm standing up nice and straight and tall. I'm going to be looking forwards. I'm going to be flexing my stomach muscles so my core is nice and protected, and then I'm just going to lower my bottom down to the chair. Ideally, you want to be looking forward too. Don't look down because then you curl your back. That's not what you want to be doing. So looking straight ahead, 10 repetitions, breathing properly. Here we go. 1. 3. 4. 5. 6. 7. 8. 9. Whew. And 10. Excellent. So those are our squats for our legs. Next exercise we're going to do is let's do some bicep curls. You guys always know I bring my trusty gym bag with me to work every day. So this is what I'm going to use for my weights. Just grabbing a stack of magazines that I have lying around, put them in my bag. There we go. So that weighs about 5 pounds or so, which is pretty reasonable. So for bicep curls, that works the muscle here in the front. So I'm going to be standing shoulder width apart, good base of support, standing up nice and straight and tall. And then I'm just going to be curling my gym bag up to my shoulder and back down. And once again, 10 times. 3, 4, 5, 6, 7, 8, 9, 10. And then we'll do the other arm. And I'm just going to show you another option here. If you find that the bag's a little bit too heavy, I've just got my water bottle here. A 500 ml water bottle weighs about a pound. A liter weighs about 2 pounds. So you can always do this as well. With a soup can or a big water bottle works too. 2, 3, 4, 5, 6, 7, 8, 9, and 10. Good news about using a water bottle: when you're done, you can have a drink. Okay, we're going to finish off with our stretches. Start off with the back of the arm. We'll stretch the triceps. So arm out in front of you, cross your shoulder, and then you're just pulling with your hands. Hold the stretch for about 15 seconds or so. Okay, now let's do the other arm. Out in front, pull it across your body. Okay, that's good. Next one we're going to do for the chest. So lace your fingers together behind you. If you can't reach, just go as close as you can. Pull your shoulders back. And looking up to the roof, you'll feel a stretch through your chest through here. Making sure to breathe comfortably. Okay, good. Now we're going to do our runner stretch for our calves. So find a counter or something that's going to be pretty solid. Both feet flat on the ground, both feet pointing forwards, and you should feel a pull in the back of this leg here, in the calf, the lower part of the leg. Okay, let's switch legs. All right, let's finish off with our hamstrings. So sitting down on a chair, just wiggling your bum towards the front edge. One leg out in front of you nice and straight, and then just reaching forward as far as you can. You feel a pull here in the back of the straight leg. And I've said this before, everybody needs to do this stretch, myself included. So many people have got tight hamstrings, which cause a lot of problems. Okay, let's switch to the other leg. Holding that for about 15 seconds. All right, folks, you can shake that off a little bit. I'll come closer to the screen. And let me see if I can get my share screen here. That one, share, make bigger. Look at that, Crystal, I figured it out again. Okay, so that's it for our session for today and this week. Fridays we don't do anything. But on Monday, my colleague Renee Canidis is going to be talking about how to problem solve when you're trying to make behavior change and running into problems. Goal setting and trying to find ways to leave heart-healthy behaviors. It's not always really simple and straightforward. So on Monday, she's going to spend a little bit of time talking about ways and strategies that you can adopt to help solve some problems you might come up with. And also on Tuesday, Dr. Ashley Heidema is going to be talking about gender differences in heart disease. Some of you might remember Dr. Heidema. Ashley worked with us here for a couple of years, and now she is working at London Health Sciences Centre. She's absolutely a fantastic speaker. I've heard a version of this talk myself, definitely worth catching. So if you guys get the chance next Tuesday before our 1 o'clock exercise session, tune into Ashley's session on at 10 a.m. on that same day. Okay, and that's it for me. I think I saw a couple of questions. Let me just see if there's anything I can do quickly. From Mike, sometime could you talk about any differences in approach, duration, intensity for male patients versus female patients? So how about we see how things go on Tuesday with Dr. Heidema, and then see what we do after that. Can exercise reduce your cholesterol levels? Are you stuck with medicines and diet as your options? So exercise can impact on your cholesterol, but admittedly not an awful lot. There's different types of cholesterol out there, Mike. There's what we call good cholesterol, which is HDL, and bad cholesterol, LDL. So exercise is a great way to try and increase your HDL cholesterol. It doesn't do it dramatically. You know, the target for HDL cholesterol is to try and get it to at least 1.0 or higher. If you exercise, you might be able to increase it about 10%. On the LDL side, exercise doesn't help an awful lot. So with lowering LDL, the vast majority of that is going to be through diets. And of course, medications. Statin medications are an important drug in the management of coronary artery disease. And only one of the ways that statin medications help with coronary artery disease is by lowering LDL cholesterol. Is it true the liver produces cholesterol? Yes, the vast majority of the cholesterol in your body is actually produced by your liver. So if you've got a horrifically bad diet, and then you go to a perfect, pristine vegan diet, you might lower your LDL cholesterol maybe 30, 35% or so. And that's because most of it's produced by your liver. And another talk from Jerry. That's the Jerry I know from my Wednesday class. How you doing? Jerry, medication and sunburn effects. I will keep that in mind. Maybe we can talk about that. But with the hot weather coming up, I'll have a little refresher. And then Anonymous, you mentioned improving blood flow without medication. I read in Cardiac College exercise session that aerobic exercise of 5 to 6 hours per week can improve. Can you talk about this? Anonymous attendee, that is my absolute favorite topic, talking about regression of coronary artery disease. I can't answer that right now because I won't have the time to do it justice. I do know it's possible, and I'll definitely keep that in consideration for a future session. All right, on that note, folks, I am going to end. Thank you very much for joining in. Hopefully you guys were exercising with me for that whole time. Keep putting in the questions. We are tracking them, and I'll do my best to answer them in the couple weeks. All right, thanks, folks. Have a wonderful weekend.